we all know that it affects a lot of people, and that number is increasing day by day. Once we are hitting about the age of 85, the prevalence of cognitive impairment is significantly higher. And what is interesting, I only learned this recently, which is probably something that people who are psychogeriatricians have known for a long time, which is actually the kind of behavior that people demonstrate when they develop dementia has got something to do with their personality before becoming ill, and kind of like 4 kinds that have been described: secure, dismissing, fearful, and preoccupied, which are the kinds of behavior you also see when people develop dementia. The reason why it's important, because it is the commonest cause for developing delirium in older people coming into a hospital. One of the key things, of course, we have in the emergency department is lack of access to the right kind of information. So frequently you will find somebody being brought in, obviously, at 11 p.m., 1 in the morning, 7 in the morning, with complaints of confusion, and it's kind of hard to tell a lot of the time whether the confusion has been old or is it new, which is one of the key things we obviously want to know, because that is really what we are kind of interested in. Although I have to say, from the emergency department setting, I think the key thing is to appreciate that somebody has got confusion. Even that is going to be a massive step forward, because we do miss that a lot. But appreciating the fact that they have got confusion is important. And then being able to get the information that allows us to differentiate between, is this dementia or is this delirium, is obviously the next step. But again, I re-emphasize, we don't need to get hung up on making that differentiation. If that is not possible at 1 o'clock in the morning, it's not important. The key thing at this stage is probably the safest thing is to assume it's confusion of new onset, unless you know that it isn't. So at 1 in the morning, you can see why a lot of the time some decisions will be taken which may not necessarily be appropriate and maybe a bit too much for the patient concerned. But that is more to do with a failure in the system rather than in the failure of the clinician to provide appropriate care. Without a lot of information, it is not possible to work on a lot of these issues. But in an emergency department, the situation isn't always that helpful. So I'll let you read that. Can you see that at the very end? Okay. Does that look familiar? Anybody been there? Not yet? Or been there without knowing? So, does happen. Okay, so let's see what we can do to move away. But some of those terms are probably quite common, and they kind of vague hysteria, didn't really know what was going on. You still hear the term acopia? Yeah, it's still there. Okay, I suppose when somebody's got a medical problem, it is difficult to cope, isn't it? But we turned that into a diagnosis in itself, which we used to a lot more in the past. It's certainly changed. So let's look at delirium. Very common. So on an average, if you were to look at a Bandor National Health Service hospital, about a quarter of all the patients in the hospital at any moment in time have got cognitive impairment. It's a massive number. 70% of the beds in any standard hospital in this country are taken up by older people. The bed days, 70% of the bed days are taken up by older people. Providing better care for older people is really important because it makes our hospital more efficient, more effective, and certainly more compassionate. So if you look at the different settings, obviously the incidence varies. When we're looking at delirium, the two things we need to think about is what were the predisposing factors which makes somebody an increased, increases the susceptibility, and of course the second thing is what has precipitated the insult in the second place. So this is a useful way to think about it. This is from Sharon Inu's fantastic paper on delirium. For those of you who haven't seen it, there's this whole concept of this host versus agent and how the environment works. And you can see how a frail older individual with high comorbidity and obviously also pre-existing dementia is high risk in terms of vulnerability, and you need something very little, just a couple of tablets of codeine, 30 milligrams each, to drive them into becoming delirious. Whereas in somebody who is 30, you probably need a good going pneumonia with hypoxia and full-blown severe sepsis before they start getting delirious. So that is where the thing lies, is kind of understanding that the threshold for developing delirium in an older person is obviously lower, which was the same thing with the whole trauma thing. It's like falling down a full flight of stairs is similar to you or me being hit by a Land Rover at 50 miles an hour. The threshold at which harm tends to happen has been changed as a result of frailty, and that is what makes them more vulnerable. Obviously, don't expect everybody to remember that, but I think it's important to remember that there's a big list of predisposing factors and a big list of precipitating factors, out of which if you had to look at the more common ones, so certainly infection is fairly common, as is electrolyte imbalance or different kinds of deficiencies, drugs, but actually simple things like putting in a urinary catheter or failing to do a rectal examination in somebody who's been constipated for a long period of time that's also gone into urinary retention could actually be the reason for precipitating the onset confusion. The key things to think about is that these are the people who are at highest risk. So if you look at that, any person with a hip fracture, any older person with a hip fracture is a high-risk person for developing delirium. Any kind of illness or existing or new cognitive impairment. I think one of the key things here from an emergency department setting, which makes it particularly challenging, is this thing about observing at every opportunity. So how many of you work in emergency departments? Okay, and how many of you have got patients moving out of the emergency department every half an hour, 1 hour? Okay. Exactly, I was going to say, where do you work? So on an average, our patients are probably waiting in a bed for 7-8 hours. Must be, I think, I may be exaggerating, maybe 6 hours. Is that similar in Europe? Yeah. So we are very much part of the European Union, aren't we? So we have got a very similar flow. Now, what's quite important to remember is that unlike a medical ward, where once you have got a full unit, you don't accept any more patients, we don't have that luxury. Patients are constantly coming in. So the nurses are expected to keep observing those lying in a trolley for the last 7 hours, waiting for a bed, as well as all the new patients coming in constantly. It is a massive cognitive load. People make mistakes. The system forces people to make mistakes in these surroundings. So it is really difficult to pick up the fact that this person who actually had the fall at midnight was found lying on the floor at 7 in the morning, was brought into the emergency department at 1 o'clock in the afternoon, and is now needing to be observed at 4 o'clock in the afternoon, has already gone through a huge duration of no fluid, no food, in an alien environment, getting dehydrated, also getting rapidly more tachycardic, the pain. You're creating the perfect environment for this person to develop delirium. Okay, and we haven't even given them morphine or dipped their urine. So we are in a different league in terms of trying to prevent this from happening. And if you think about it, the system is setting us up to provide poor care to these patients. So the problem is the system. We need to address how the system works and the processes work. It's part of the entire continuum. 4 things to think about when you're looking at, think of cognition. You've got a confusion, you onset. What's happening with the perception? So they tend to get hallucinations. Physical function is obviously an issue here. And I think the key is reduced mobility, reduced movement, because that gets easily missed. So this is the 90-year-old lying very quietly in the trolley without making a fuss, as opposed to the one who is stood up and is telling, get me out of here now. That's the tiny minority, but that is the one we plug on like that. Whereas the ones who don't are the ones we tend to miss. So it's important to remember that. Social behavior, lack of cooperation, independent person. So what is triggering it off? So one of the key things here is acute stress. So if you've got pre-existing cognitive impairment and I pick you up from your normal surrounding and you stick you into an emergency department, especially if you come to Leicester, there's no natural lighting. It's bad enough for the staff. Wonder what it does to the patients. You don't know what time of day or night it is, and you get completely confused in that setting. And along with that, if you add the whole environment, it is understandable why older people tend to suffer harm. But actually, EDs are not traditionally designed to be older friendly, which is something we need to think about as we move forward. But some of the common things to be aware of, is like fluids. And I've got this simple 4H and 4Ts, which I'll talk about later, because all we use 4H and 4Ts to try and remember what we can do about it. But the important thing is that delirium is a medical emergency. And that is not the way we look at it. In fact, we've got a code of delirium. We've got delirium superimposed on dementia, delirium something, but I don't think these codes are ever used. Would you agree?
Yes.
Yes. So Chris has done some work on it. Chris is one of the geriatric medicine SPRs in Leicester, and we know those codes are pretty much never used, because what we tend to use are things like infection, or a fall, or drug effect, which could be lots of different things. It doesn't mean that they come with a delirium. But again, sometimes we actually do say delirium, and we are far better off at picking up the infections, but we tend to ignore the other causes. So, and it's kind of easy to pick up the infection, especially when you dip the urine, and that is why I'm very cautious about it, because once you've dipped the urine and you've labeled it a UTI, you've probably missed every other reason for this person having delirium in the first place. And that is where the danger lies. It's not so much having a diagnosis, it's this fear. I'm afraid of labeling anything, because it just makes it harder to move on. And you'll see why, because first of all, we easily miss it when it is present, and missing it, look at the number of times, 57%, 83% of the times in an emergency department, delirium is missed. By the way, these figures are from the US, so they're not vastly different here, and so it is not unique to a UK emergency department. I think it's unique to an emergency department setting, because of the environment we work in that causes this to happen. 25% of delirious ED patients are discharged home. Okay, how can we discharge somebody safely without knowing what their cognitive state was like? All right. So it's quite important. So the College of Emergency Medicine, we did a national audit to find out how many older people above the age of 75 who were brought in a trolley by ambulance. Don't go to research, not the sickest of people who are sitting and talking, did we do a cognitive assessment on. So you'll see that the highest was 19% of this population. That was the upper quartile. Median was 11%. But look at the figures for communication of assessment findings with relevant services, carers and GPs. Admitting service. So where we are admitting the patient, we are good at saying there is a problem, but where we are discharging the patient, or the patient is being admitted and is new onset, we are passing on the information pretty much never. Okay? There's probably quite a lot of, this is obviously based on the documentation, so it may be happening in real life a bit more than what that picked up. But what it clearly shows is that there was a problem. Now, the areas that we're doing a structured cognitive assessment, we're actually using a proper tool to do it, and we have got a list of all the tools that were used if you look at the audit, which is available online. But actually, we're kind of missing a big trick here. And in some ways, the way I think about it is that if you do not know, if I was confused when I gave you the history, how on earth could you come and do clerking on me and start managing me without knowing whether I was telling you the right stuff or the wrong stuff? It completely puts the whole medical history taking model into serious doubt when you don't know whether the person was cognitively intact or not. So, typically presentation 3 ways. So the hyperactive ones is the ones we pick up, and this is the group that is very easy to spot they've got a problem. However, the commonest presentation is the group who lies still. Gives you a little smile when you pass by, or doesn't look at you and lowers their head. This is the group that we miss, because sometimes we think they may be depressed, or sometimes we don't question it because they're not causing a problem. And this is the hyperactive type, where along with the mixed, which are the commonest presentations of delirium in the ED. It's different in different settings. But what is interesting is that certainly some papers have shown, Christian here is a real authority on delirium, and I think it was Hahn's paper from the US, which showed about 96% of delirium in the ED tends to be hyperactive and mixed. So it's by far the commonest type. What can we do to stop it from happening in the ED? Well, first of all, avoid benzodiazepines, cholinergics. You may not have heard of this thing called the HELP program. Again, this was Sharon Inno who started this. Basically, they tried to set up a lovely environment for older people, kind of hard with the resource constraints within our existing emergency department setting. However, there's quite a lot of different things we can do. For example, visual and hearing adaptations. We're trying to buy some for our ED, which definitely will help, making people more aware about managing pain, looking for constipation, doing blood scans for urine retention, and certainly avoiding putting in a catheter. So the key thing I would say, the question to ask is, why am I putting in a catheter? The answer is because I want to monitor the urine volume. At which point the question is, can you measure it once they've had a wee in a bottle? If the answer is yes, then why do you need a catheter? Because it makes life easier, which is what I do here at times. Well, whose life easier is the question which follows, which is not the patient's. And you're certainly adding to the number of coties in the hospital by sticking in catheters. So if you have to put in a catheter and this patient doesn't have a history of long-standing urine problem, you could do it in and out. It doesn't have to be left in. But the best thing is avoid it. Some of the things we can do. This is a little bit harder, but can be done. Making your emergency department more geriatric friendly by having low trolleys, guardrail signage, a more sympathetic decor, natural lightings. If you think about it, about 60 to 70% of all your trolley patients are above the age of 65. So if you didn't think you were working in a geriatric ED, you already are. All EDs are geriatric EDs. If you take out minors, if you take out peds, and you take out resus, what you're left with is a geriatric ED. So we don't need a geriatric ED. We already have the skills and competencies to make it work. We just need to slightly change the environment within which we do it and some of the processes that we do to make it better for the older people. If you want to look at the evidence behind some of this stuff, it's all published with the Department of Health. That's the health building notes on dementia-friendly design, and you can have a look at it, freely downloadable. It'll tell you all the stuff you can think about for making your environment more friendly for older people.